You say ascites, palmar erythema, edema in the legs. Okay? And symptoms of liver cirrhosis are all described what you saw earlier to the segment. The physical findings, skin pigmentation, and all these pictures you can remember and try to say a few things which will have be told in the examination. And this is a classical picture of how patient looks emaciated at the upper part of the body and looks very fat, and so this is described as poverty above and prosperity below. Now, what are the causes of liver cirrhosis or types of liver cirrhosis? Alcohol is very common nowadays because of the free supply, encouragement from government to drink. But apart from that, what are the other causes for to develop a cirrhosis?
Non-alcoholic steatohepatitis, post-necrotic cirrhosis, and primary biliary sclerosis and secondary biliary sclerosis, Wilson disease and hemochromatosis, alpha-1 antitrypsin deficiency, post-traumatic, post-necrotic.
So, alcoholic, post-necrotic, primary and secondary, non-alcoholic steatohepatitis, hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency. Now, what are the phases of cirrhosis? How does it develop?
That may be compensated and decompensated phase.
Very good. Okay. So, phases are compensated and decompensated. What are the changes in the various systems which happen, which you already described? So, the effects of cirrhosis on other systems of the body, you can remember by the mnemonic chief ranges. Okay? So, starting from C, it is about CVS. So, you have in CVS, what are the changes? You have a decrease in SVR, increase in cardiac output, and so the pulse looks very hyperdynamic and bounding. So, there is a hyperdynamic circulation. Okay? What is about H? Can you guess what could be the H?
Hematology.
Hematology. So it could be anemia or coagulopathy. What about I? Is immune, decreased immunity, producing spontaneous bacterial peritonitis, or patients easily going for sepsis. And E
is
electrolyte imbalance. Okay. And F
fluids.
Fluids, hypo or hypervolemic state. R
Renal.
Renal, yes, renal syndrome, or respiratory and renal. Both can be remembered by R. So it can be
hepatopulmonary syndrome
hepatopulmonary syndrome or pulmonary hypertension, orthodiastria, pulmonary hypertension, and hepatorenal syndrome. So the first four are for respiratory system. The last one is for the renal system. So what about A?
Is acid-base balance, sir.
Acid-base balance and albumin. There is a decrease in albumin. What is the importance of albumin in patients with cirrhosis?
Albumin is the liver is the production of albumin, sir.
If liver is the only site of production of albumin in the body. Very good. So,
due to decreased oncotic pressure and increased hydrostatic pressure, there may be fluids.
That is the effect of low albumin. Because liver albumin production decreases in patients with decompensated liver disease. But can it be taken as a marker of the degree of decompensation of liver disease?
Yes, sir.
Yes or no?
Yes, sir.
Okay. Are you sure it can be taken as a immediate acute marker?
No, sir.
Why?
Because it is a half-life was 21 days, sir.
Very good. So it is a slow marker. So if you find a patient with a very low albumin, that means he is in a very severe decompensated state, because in the early stages you may find the albumin to be normal because it has a half-life of 21 days. Whatever albumin has been produced and released in the circulation will maintain the level. But if the albumin level has grossly gone down, that means the patient is in an extreme stage of decompensation. In that way, it is a very good marker. But if you want to see the acute condition of a decompensation, which one will be a better marker?
Prothrombin time, sir.
INR, prothrombin and INR, because of the coagulation, they are also proteins. Those proteins are also not properly produced. So, an acute marker of liver disease will be prothrombin time and INR. A chronic marker of liver disease, which gives extreme degree, will be albumin level. Okay? That is the importance of albumin. Then N for
Nutrition.
nutrition, lack of so due to anorexia and absorption. G for
GIT, gastrointestinal tract.
gastrointestinal and glucose metabolism. So gastrointestinal, they may have esophageal varices, nausea, vomiting, and hypoglycemia. And E for encephalopathy, flapping tremors, which are all extreme stages of liver failure. Okay? And last S for
Skin,
SCID,
sir.
pruritus, petechial hemorrhages. Okay, so these are all the various things, 11 points you can remember by this mnemonic. It is very easy to recall and write both for your theory exam as well as in the Viva. You can remember the changes that happen in various systems. If the examiner asks you this, you can recall by using this mnemonic. Okay? Now, describe the stages in the development of DCLD or cirrhosis. So, what is the histologically, how does it go? You said that it is a type will be compensated and decompensated. But if you see the structure of a liver, how does it change during the development of cirrhosis? What are all the stages it will go through? So this is the picture you have to remember. This is normal liver. When it becomes infiltrated with fat, it becomes steatosis. Then it causes an inflammation which leads to steatohepatosis. Then it leads to fibrosis. Fibrosis causes shrinkage in cirrhosis. And if it is left a long time, finally some patients may develop hepatocellular carcinoma also. Okay, so these are all the various stages through which it goes. Describe how ethanol is metabolized in the body and how it can cause the problem of liver damage.
It occurs in cytosol and mitochondria pathways, sir. Ethanol is converted to acetaldehyde with the help of acetaldehyde dehydrogenase enzyme, and then it enters into the mitochondria. That step occur in cytosol, and other than next is mitochondria. Acetaldehyde is converted to acetate with the help of aldehyde dehydrogenase. Aldehyde dehydrogenase.
So, alcohol dehydrogenase and aldehyde dehydrogenase. These are the two very important enzymes which help in the metabolism or breakdown of ethanol that's consumed. So the first step happens in the cytoplasm of the liver cell. And there the alcohol dehydrogenase, because you are taking alcohol, the first enzyme to act on that is alcohol dehydrogenase, which converts this ethanol into acetaldehyde or acetate. And this acetaldehyde is transferred into the mitochondria, where it is converted into acetate by acetate dehydrogenase or acetaldehyde dehydrogenase, the second enzyme that is there which causes this second consumption. So this is the major important way it is metabolized in the body, which can be the common question they may ask you. Describe the anatomy of the liver. Sometimes the examiners are fond of asking anatomy and physiology, all the basic sciences of the liver. So how will you describe the anatomy of the liver?
The liver is the largest gland in the body, sir. It weighs around 1,200 to 1,600 grams, sir. It is located in the right hypochondrium, umbilicus, and left half of the left hypochondrium. It has dual blood supply, which portal vein is 75%, and hepatic portal vein 75%, and hepatic artery is 25%, sir. And,
you are not mentioning the lobes. How many lobes or segments are
anatomical classification, right lobe and left lobe, sir.
that
It's
is
separated by falciform ligament, and structurally segmental classification by Kuno classification, right? With the middle hepatic vein, it separates right left lobe. So,
very good.
So
the liver
right
is
lobe 5, 6, 7, 8.
connected to the diaphragm for falciform left ventricular segment, and it has got a anterior large right lobe and a small left lobe is there, and the lobes are divided into right and left, and right lobe has two minor lobes, what is called the caudate lobe and the quadrate lobe. Okay? And the surfaces are, you must know the anatomy, because both the undersurface as well as the frontal surface or the gastric surface, and these are all the important things. This anatomy is important because when you have a live donor, from where will you take the liver?
Right lobe of the
Take it from the right or left?
left lobe, sir.
Usually, this is easy to take the left lobe, part of the left lobe. Okay, so that is the reason why we must know some knowledge about this anatomy. And the segmental anatomy is where the Winard classification comes, which is known as and it is the preferred anatomy classification as it divides the liver into 8 independent segments. So in the early days of liver transplant, they thought they can take only the entire small portion of the left lobe. But later on, they found it is not necessary. You can take even small segment. What is the idea of taking a small segment and putting it in a patient for treating him from end-stage liver disease?
Will regenerates the liver is the regenerating capacity.
Liver has got enormous potential to grow very fast. Why? How is it possible? Why liver has this capacity to grow so fast to become a bigger gland?
Separate hepatic the portal triad, hepatic artery and hepatic vein bile duct system.
Portal triad is there for all the segments of the liver. But when you take a small portion of the liver, like a small segment, and transplant it into a patient with end-stage liver disease, how does that liver grow and become huge to function normally in that patient? If you take an ultrasound after 3 months, it will be as big as a normal liver, even though you have just transplanted one small segment. How is it possible?
By hypertrophy.
What is the basic
it has separate outflow, inflow and outflows.
It is based on the embryology. It is which type of cells give rise to the liver cells? Is it a pluripotent cell or a unipotent cell?
Pluripotent cell.
Pluripotent means multiple cells will develop from one cell. That is called pluripotent. Plural. Is it a pluripotent cell? Your blood, neutrophils, eosinophils, basophils, hemoglobin, all these RBCs, they are all pluripotent cells. They work from one stem cell, you are developing all the other cells. Okay. Yes. Whereas liver is unique in that it is a unipotent cell. One stem cell of liver will grow only into liver cells. It cannot go into other tissues. Okay. That is the reason why liver has got such an enormous capacity to regenerate, and that is the success of the liver transplantation. And so this is the picture of Kuno classification based on the intravenous venous supply, IVC and its branches, hepatic vein branches, and there are functional divisions. This is more for those who want to become liver transplant anesthetists, and they should know all these things. But at least remember that there are 8 Kuno segments which are mainly based on the hepatic vein divisions, right? Middle, right, and left hepatic vein divisions. Now describe the blood supply. What is the peculiarity of blood supply to the liver?
Dual blood supply, sir.
Dual blood supply for both nutrition and oxygenation and single hepatic venous drainage. Okay, so it is a dual supply with artery and partly oxygenated blood from portal vein and a single venous drainage with a hepatic venous system. Okay? This is the important thing. So it has got 25 to 30% of cardiac output is coming to the liver. There's a portal venous supply which is about 75%, where oxygen saturation is only 85% in that. Whereas the hepatic artery, which gives mainly all the oxygen requirement for liver, is a 95% saturation, and oxygen delivery is 50% by both, and 2/3 of the oxygen used by the liver. Sinusoids can accommodate 400 to 600 ml of blood, and the venous system is by the sinusoids drain into a central vein, which drains into hepatic vein. So what are the types of receptors present in the portal vein and hepatic artery, and what is its importance?
Hepatic artery, alpha and beta and dopamine receptors are present, sir. In portal vein, only alpha receptors present, sir. So it is used for vasoconstriction. So in portal vein, noradrenaline will use.
Okay. So we have portal vein, there is only an alpha receptor, whereas hepatic artery you have alpha and beta receptor. So all the drugs, dopamine, dobutamine, noradrenaline, according to their location of action, they can have the effect on the vasculature of the liver. How is the blood supply to the liver regulated? What is the, when this question is asked, what do you have to describe about?
It is a extrinsic regulation and intrinsic regulation, sir.
Very good.
Extrinsic regulation through neural control and hormonal humoral control. In intrinsic pathway, hepatic arterial buffer response and auto regulation, pressure flow auto regulation, and myogenic risk.
So there is an intrinsic regulation and extrinsic regulation. Extrinsic you have neural and humoral, whereas the intrinsic you have the hepatic arterial buffer response, which is the very most important thing which we have to keep in mind and preserve this as far as possible. And pressure flow auto regulation and metabolic control. Okay, the pressure and flow also determine the intrinsic mechanism, and the demand by the metabolic activity also increases. So this hepatic arterial buffer response is sometimes you can get it in the theory question. So what do you mean by that? Whenever there is a drop in the portal venous supply, what will happen to the hepatic arterial blood supply?
That is increase in hepatic arterial flows, reciprocal changes.
Will increase the flow to compensate for that. But the vice versa, can it happen?
No, sir.
And there is a fall in hepatic blood flow, arterial blood flow. Will the portal venous blood flow increase?
No, sir.
It cannot. Okay, so that is the important mechanism which you have to remember. And the drug or the chemical that is responsible for that is adenosine.
Adenosine.
Okay? So that is how the hepatic artery will dilate and allow more blood to flow whenever there is a drop in the portal venous circulation. So that is called the major response. There is a pressure flow auto regulation and metabolic control, which is also decrease in oxygen tension or pH, increase in PCO2, all this increase hepatic arterial flow. And postprandial hyperosmolarity also increases hepatic arterial and portal venous blood flow. But if the patient is in fasting, this will not happen. So what is the importance of this particular point, where postprandial hyperosmolarity increases both hepatic and portal flow, but in fasting state this cannot happen? What is important? So these patients should not be fasted for too long. when they are waiting for surgery, patient with already a decompensated state should not be fasted for too long. Okay? So you have to follow the current regulations of guidelines of fasting and keep them taking something so that this fasting will not decrease the blood flow even before surgery is started. And the underlying metabolic and respiratory causes also modulate the distribution of flow within the liver. What is the sympathetic and parasympathetic supply and their effects on the liver?
Vagus
Autonomic
nerve.
control.
Parasympathetic due to vagus nerve, sir.
What is the, see, whenever you were asked about the nerve supply, you must tell the basic nerve roots from which they are supplied, isn't it?
Yes, sir.
So neural control fibers of vagus, phrenic and splanchnic nerves, that is postganglionic sympathetic fibers from T6 to T11 enter the liver at the hilum. When the sympathetic tone decreases, splanchnic reservoir increases, whereas sympathetic stimulation translocates blood from the splanchnic reservoir to the central circulation. Vagal stimulation alters the tone of the pre-sinusoidal sphincters, and the next effect is redistribution of intrahepatic blood flow without changes in total hepatic blood flow. Okay? That is very important. So, parasympathetic supply is from vagus and phrenic, whereas sympathetic supply is from T6 to T11. That is what we have to remember. What hormones have effect on liver blood flow?
Glucagon and catecholamines.
So gastrin, glucagon, secretin, bile salts, angiotensin 2, vasopressin, catecholamine, cytokines, interleukins, and other inflammatory mediators have been implicated in the alteration of normal splanchnic and hepatic blood flow. So it is not only glucagon, catecholamine, all the other hormones also have some effect on this.
Yes, sir.
Enumerate the factors increasing and decreasing the liver blood flow. What factors will increase the blood flow and what factors will decrease the blood flow? Because this is a very important point that we have to remember, so that during anesthesia, we don't decrease the blood flow. Our aim is to always preserve the blood flow, whatever level is there before induction or before surgery has to be maintained throughout to prevent an acute hepatic failure. That is the most important goal in the management. So the factors can be that increase are hypercapnia, acute hepatitis, supine posture, food intake, as we saw, starving state, blood flow decreases, and drugs, beta agonists, phenobarbital, and enzyme inducers, all these things increase the blood flow. Factors which decrease the hepatic blood flow are IPPV. Whenever we do controlled ventilation, we should try to avoid too much of PEEP or the airway pressures. Hypocapnia, hyperventilation, and washing out of carbon dioxide should not be done. No hypoxia. Patients who have already developed severe degree of cirrhosis because of the severe contraction of the tissues, blood vessels are collapsed and blood flow will be decreased. Alpha stimulation, beta blocker therapy, allothane and volatile anesthetic agents, they cause a dose-dependent decrease in the blood flow, and vasopressin also causes a decrease in the blood flow. Okay? So these are the factors that we have to remember. Now applied histology. What are the different lobules described by histology and what is their importance? How many lobules or a group of cells are described in histology?
Hexagonal. One is hexagonal shape support.
Each has got a name. Anybody else?
Classical lobule.
Classic hepatic lobule, very good. Okay, then ileal Yeah, Bindu, Ranjini, anyone answer this question? So there are three important things. This picture I am going to show you will tell you this is the classic hepatic lobule, which has got a hexagonal structure, six-sided structure, which all of you. It is all imaginary line. It doesn't look like that when you cut and see that. But the arrangement of hepatocytes gives you an imaginary feeling that this is like a hexagonal structure with a hepatic portal system here, the entry. So this is considered a portal vein, hepatic arteriole, and the bile duct. And they all try to go, the blood flow occurs from here towards the central hepatic venule. This is called the classic hepatic lobule, drains blood from the portal vein and hepatic artery to the hepatic or common central vein. This is the classical hepatic lobule. Then there is a portal lobule, where it is a triangular imaginary shape given by connecting three adjacent portal central veins. Okay? So here, this is mainly for drainage of bile from the hepatocytes to the bile duct. So whatever bile is secreted from the hepatocyte, they all will drain towards the bile duct, towards the at the corner of the hepatocytes. Okay, so this is the second imaginary lobule, and the third is the portal acinus, which has got a diamond shape instead of the hexagonal and the triangular shape of the other two. It has got a diamond shape. This is also six-sided structure, but little elongated like a diamond. And here, this is the main thing for your metabolic activity, where all the metabolism of drugs take place. And so the hepatocytes, which are very close to the hepatic artery and portal vein, they are called the cells present in zone 1. They receive the most oxygen, and they have the highest metabolic activity of digesting our fat, glucose, proteins, everything. Then cells which are situated a little away, they are called the zone 2 cells, where they receive less oxygen compared to the zone 1. And the third group of cells which are situated in the zone 3, they receive the least oxygenated cell. And these are the cells which do the normal the basic enzymatic activity of hydrolysis, uh, the basic type 1 and type 2, all the basic enzymatic activities are done here. So any hypoxia will first affect the zone 3 cells, and that is why the enzymatic activity becomes deranged, and you go in for all the complications. So these are the three important imaginary divisions. It is not classical histology, but this is how we try to create the structures to understand their functions. So classic hepatic lobule is the main blood supply, how it drainage, arterial blood coming and venous drainage happening. Portal lobule is for the drainage of bile, and the portal acinus is for the enzymatic activity and the activities of the hepatocytes to describe the availability of oxygen to the various groups of cells. Okay? And what are the names by which the zones are called? It's called periportal zone 1 because it is close to the porta hepatis. The zone 2 is called mediolobular because it is little away from that, but it is present in the hepatic lobule. And zone 3 is called centrilobular because it is very close to the central vein. And what is the function of these zones? Of course, I told you all that. Zone 1, highest oxygen supply, so increased metabolism and protein synthesis. Zone 2, less oxygen than zone 1, so intermediate enzymatic activity. And zone 3, lowest oxygen, high cytochrome 450 activity. So this is the three zones and their activity. And this is a very important concept that you have to keep in your mind. Enumerate the various functions of liver and how they happen. This is another basic physiology question they may be asking you. How do you classify the liver functions?
Protein metabolism and catabolism, carbohydrate metabolism, synthetic.
That all that can be grouped as metabolic functions. Metabolism of liver.
Metabolic functions and synthetic function.
Synthetic function.
Reservoir of blood and procoagulants and coagulants.
That coagulation factor, albumin, all that will come under synthetic function. Okay, yes. So you can functions of the liver can be first and foremost it is a very good reservoir of blood. So whenever there is a need for your acute volume replacement within the body, if you undergo a trauma, liver will be the first organ to squeeze its blood into the circulation to maintain your volume status. Okay, so it has a very enormous 1 to 1.5 liters of blood can be pumped in from the liver into the circulation. Then it maintains glucose homeostasis, fat metabolism, and protein synthesis, which are all main metabolic activity. Then detoxification function or drug and hormone metabolism. Then bilirubin formation and excretion, antibacterial activity or immunological function. So looking at each one of that, 10% of the total blood flow goes to the liver. So it's available for auto transfusion into central circulation and prevents profound hypotension after minimum blood loss. So this is how the liver helps as a blood bank for our body, and it is under neural and humoral control. Now coming to the glucose homeostasis, all of you know that glucose goes to the hepatocytes, and catecholamines and glucagon or insulin are the important hormones, and it is converted to lactate, glycerol, amino acids, and it is utilized or stored as glycogen in the liver. Similarly, lipid metabolism, free fatty acids becoming triglycerides and VLDL, and then all these things. And the importance of this is beta oxidation of free fatty acids converts it to acetyl-CoA. This is how the ketone bodies are produced in the body. So whenever we go in for ketosis, this is the mechanism that they will ask you in patients with diabetes. Okay, and protein, of course, synthesis of amino acids, and another important thing is formation of urea from ammonia. That is also taking place in the liver. So under the protein metabolism, we have to remember that. And all plasma proteins except gamma globulin and factor 3, 4, and 8 of coagulation factors are all produced only in the liver, except gamma globulin, factor 3, 4, and 8 of coagulation factors are all produced in the liver. And the most important of that is albumin, and the daily production of albumin is 12 to 15 grams per deciliter, and it is a negative acute phase reactant. So you can take it as a marker of acute phase reactant also. In liver disease, it goes down and globulin levels increase or become normal. So this is what is called the reversal of albumin globulin ratio, which is also a significant factor for assessing the damage to the liver. And the liver, as she rightly said, maintains the plasma oncotic pressure, and it also helps in binding of drugs and also free fatty acids, UCB, and hormone. So this is how the albumin works. And other plasma proteins are coagulation factors, transport carrier proteins like transferrin, haptoglobin, ceruloplasmin, and plasma esterases, complement factors, C-reactive protein, which is an active factor. All these things are coming under the category of the protein function. The next question: how liver products affect cardiovascular system in the body?
It can produce hyperdynamic circulation, so increase cardiac output states.
Bilirubin, does it cause hyperdynamic circulation? Bile salts and bilirubin, do they cause Hyperdynamic circulation.
Bilirubin is the effect of heart rate. Decrease the heart
Bile
rate.
salts.
Bilirubin acts on
bradycardia
SA node
due to
and
direct
bradycardia.
effect on SA node. It also impairs the cardiac contractility. It impairs response to beta agonist drugs and decreases peripheral vascular resistance. So these are all the effects of bile salts on the cardiovascular system. The result of which will be hypotensive patient prone for circulatory collapse, exaggerated hypotensive response to bleeding, more prone to perioperative shock, therefore replace volume losses immediately in perioperative phase. So it does not cause increase in the flow or anything. It always causes a cardiovascular depression. Relation of heart disease and liver disease, the two-way street. So you have to remember that the heart, if it is not functioning well, it will affect the liver, and if the liver is not functioning well, it will affect the heart. Okay? So in patients with cirrhosis, it can cause cardiomyopathy, it can the portal hypertension, portal systemic shunting, impaired cardiac beta receptor response, remodeling of the cardiac collagen matrix. All these things can happen in the cardiac myopathy because of cirrhosis. After liver transplantation, there can be stress-induced cardiomyopathy, and patients with non-alcoholic fatty liver disease have insulin resistance, subclinical inflammation, oxidative stress, ectopic fat deposition, atherosclerosis, and endothelial diseases. Whereas if a patient has a primary cardiac function dysfunction, then cardiac hepatopathy can happen in valvular diseases, cardiomyopathy, and left ventricular failure, and constitutive pericarditis, and also cardiogenic ischemic hepatitis. These things will affect the liver function. So both are interconnected. The heart and the liver are interconnected in that way that liver disease can affect the heart function. Similarly, heart disease can affect the liver function. How is renal system affected in liver?
Hepatorenal syndrome.
It causes hepatorenal syndrome.
Type 1
hepatorenal. So 10% incidence with 70% mortality. The factors responsible for the hepatorenal syndrome are effects of bile salt, endotoxins, inflammatory mediators on the kidney, and also decreased cardiac function, which reduces the renal blood flow as a secondary factor, and the ADH, which is the hormone responsible for water retention, that is becomes the effect of that becomes refractory, and there is increased level of atrial natriuretic peptide resulting in hypovolemia. So all these are the factors contributing for the effect on the kidney, which results in renal vasoconstriction of the, especially the afferent arteriole, and there is a hypoperfusion of the glomerulus, and shunting of blood from cortex to medulla happening, activation of complement system leading to tubular and cortical necrosis. So all these things cause the so-called hepatorenal syndrome. And how is the immune system affected in liver cirrhosis? We saw that patients can develop spontaneous bacterial peritonitis. So how would that happen?
Decrease cellular immunity and humoral innate immunity, CD4 and CD8 counts decreased.
Yes, patients defects in cellular immunity, suppressed function of reticuloendothelial system, especially the Kupffer cells in the sinusoid, the liver hepatocyte, impaired T cell proliferation, decreased neutrophil chemotaxis, defective bacterial phagocytosis. These are all the things that happen, which lead to sepsis, or which can be in the form of cholangitis or bacteremia, or it can be in the intestine, escape of endotoxins from intestine into portal blood leading to septicemia also. So these are all the things that are there. And in the peripheral, there may be innate immune cells, the monocytes, macrophages, phagocytosis, all these things are all decreased. You can see the arrow pointing downward, and neutrophil actions are also very much reduced, and the liver loses its synthetic capacity of all the complement and other saving proteins. So that is how the patient is prone for decreased immunity. And the coagulation, it can be decreased synthesis of coagulation factors, prolongation of prothrombin time, and vitamin K dependent biliary obstruction, defective gamma carboxylation, endotoxin hypersplenism causing thrombocytopenia. So coagulation factors are decreased and platelet production is also decreased, or platelet count is also decreased because of the increased breakdown by increased activity of the spleen, and endotoxin lead to fibrinolysis. So all the mechanisms which are required for coagulation, like platelet adhesion, then coagulation factor presence like fibrinogen, and the after the clot forms, the fibrinolysis happens much more faster, so the clot is not strong enough. So all these things lead to altered coagulation, and there is also loss of calcium, which is one of the important elements which are to trigger the coagulation cascade. So decreased absorption of this fat soluble vitamin A, D, K, E. So these are all the things which happen, which result in so common stressors are thrombosis and bleeding. But very rarely the thrombosis is also happening because of the depression of the other things, anti-hemophilic factors or pro-hemostatic factors. So if these factors are increased, then patient will go for thrombosis. These factors are all suppressed, then the patient will go for bleeding. And describe the pressure flow relationship between portal venule and hepatic arteriole. This is one of the things which we saw, which are the intrinsic mechanism of the flow regulation. So this picture, if you see here, this is the terminal portal venule, which has a pressure of 9 millimeters of mercury. And this is the terminal hepatic arteriole. These are the two sources of oxygenated blood to the hepatocytes. And the pressure in the terminal hepatic arteriole is about 35 millimeters of mercury. And between the arteriole and the venule, there is a arteriolar portal sphincter. This is the mechanism by which whenever there is a drop in the pressure and the blood flow in the portal vein, this sphincter will open and more blood will flow through that. And there is a control mechanism for the hepatic arteriolar flow also in the form of anterior sinusoidal sphincter. Before it becomes the sinusoid, there is a sphincter here also. And the sinusoid pressure is 2 to 3 millimeters. So if you watch all these, there is a higher pressure in the portal vein, there is a higher pressure in the hepatic arteriole, and there is a very low pressure in the sinusoid. So blood will always tend to flow from this direction only, okay? Unless there is a gross drop in pressure, like in an acute massive volume loss or a hemorrhage, where there will be a total loss of blood in the hepatic and portal vein. Then if the pressure becomes even lower than the sinusoidal part, there will be acute hepatic failure. And there is before the drainage at the hepatic venule, there is another control mechanism of sinusoid. So this is the direction of the flow that happens. Now, alcohol metabolism, there are two enzymes, as I told you, alcohol dehydrogenase and alcohol dehydrogenase, and also the cytochrome P2E1 is the third enzyme. Then another enzyme playing minor role is catalase, and the pathways are, it can be oxidative and non-oxidative. And variations in the genes of the enzyme, that is the one which determines alcohol consumption ability and alcohol related tissue damage and alcohol dependence. These are the three important variations that, because examiners may sometimes ask you, people who drink heavily, they do not land up with cirrhosis at all. But people who have moderate drinking, they land up with cirrhosis much earlier compared to people who have a very heavy drinking. That is because of the variation in the genetic nature of these enzymes. especially these two enzymes. If these two enzymes are very powerful, however much a person consumes the alcohol, he will be able to metabolize it without causing a toxic effect on the liver. That is how the addicts also are able to tolerate large quantities without going in for liver for several years. And pathophysiology of alcohol hepatitis, of course, the same thing, which we saw how it is affecting. And what are the systems involved in the liver? That again we have already seen. Then comes the important question of how the risk is stratified and how is it useful. Okay, how is the risk stratification done in liver disease and how it is useful? You mentioned only about the CTP scoring,
Child score, yes, sir.
child Trukart and Pew scoring. Okay,
Yes, sir.
it's a very useful cirrhosis liver, but there are other cirrhosis liver related risk factors like MELD score, CTP score, measurement of albumin, platelet count, ascites, encephalopathy, varices, and portal pressure. Now, surgery related risk sources are whether it is going to be emergent or elective, what type of surgery, complexity of the surgery, duration, intraoperative blood transfusion, and facility volume and complexity. And demographics and comorbidities, age, sex, and race of the patient, BMI, alcohol use, ASA classification, functional. All these things lead to the models, estimate post-operative mortality and morbidity. That is the main reason why we want to assess the risk involved. So based on that, we can do the patient selection, give them the informed consent, shared decision making, preoperative optimization or risk modification, and plan for the perioperative management. So if this question is asked in the theory, what is the importance of risk stratification? This is how the answer should be. You should not just write about CTP scoring, MELD scoring and stop with that. So the answer, this is mainly I have given for theory exam writing. So the risk stratification in liver is based on these three factors: liver related, surgery related, and demographic. The ultimate aim is to estimate the post-op morbidity and mortality, which will give you a clue to how to manage this or handle this. Okay? And what investigations are needed? Already you have mentioned CBC to rule out anemia and infection, and PT-INR to indicator of severity and prognosis, platelet count and thromboelastography to assess the coagulation status. LFT should contain albumin, enzymes, and bilirubin. RFT to indicator of volume status and hepatorenal syndrome. Electrolytes, mostly they may have hyponatremia, potassium, low potassium and magnesium. And USG abdomen to find out the quantum of ascitic fluid, liver and spleen enlargement. Fibroscan, which is done nowadays to assess the stage of cirrhosis by the texture, assessing the texture of the liver. And EKG and echo X-ray test to rule out alcoholic cardiomyopathy. So chronic alcohol consumption, patient coming for incidental surgery, make sure that you do a echo to rule out this cardiomyopathy before you take up the patient, especially patient chronic alcohol history coming with a fractured neck of femur. Everything may look all right, may not be in the decompensated state, but he may have cardiomyopathy and he may give you trouble in the postoperative and intraoperative phase. So always look for the alcoholic cardiomyopathy and presence of pleural effusion. Now, how CTP scoring is done? How is it used to attend the median survival? We have already seen. These are the factors taken into that: bilirubin, albumin, ascites, and she has already told about how these are things, and group A, group B, all that 1 year mortality and second year mortality, all are being taken into consideration. And why they developed another scoring system called MELD scoring system, and what is its use? This is another common question they may ask you in the Viva. When there was already a CTP scoring, what is the need for developing a MELD scoring system?
It is a model for end-stage liver disease score, sir. The patient is going for a liver transplantation. The median survival is 6 months and one year.
So
They are taking.
who should get the priority for liver transplantation? This scoring system was introduced to replace the subjective inclusions in the CTP scoring. For example, ascites is taken as a part of CTP scoring system.
Yes,
whereas ascites, you can say, I will say this is a very huge ascites. You may say it is not a huge ascites, it's a moderate ascites. So that will be contradictions. So you remove all the subjective assessments and make it more objective by taking values of bilirubin, creatinine, and the PNR, I mean INR and PT. Then you do the scoring, which will be more reliable. So that is the first reason. Second reason is to choose which patient has to go for transplant earlier compared to the other patients who are also in the end-stage liver disease. So risk assessment is done priority for liver transplant and is calculated. What predictors are used are, these are the three things, that is log serum bilirubin, log INR, log creatinine. Based on that you have that scoring, and this is the predictions that you get. 0 to 9, 6 months survival 95%, 98%, 12 months survival 93, 24 months 90%. Like that you have the scoring so that you can give priority for patients who are likely to die sooner if they don't undergo the surgery. Other scoring tools which are available are adopt LC score. So if you do very well in the exam, they may ask you what is this. This is adequate operative treatment for liver cirrhosis. And here the things taken into consideration are patient age, CTP score, Carlson comorbidity index, and estimated duration of anesthesia. So based on that, you have these are the things which will happen. The other comorbidities that may be present there. There is a calculator, so you don't have to worry about it. You feed all these details and it will calculate and tell you. Then there is another thing called ALB score, where albumin bilirubin score or grade was originally developed as a measure of liver function in patients with hepatocellular carcinoma. But ALB calculated on the basis of two objective laboratory values, namely albumin and bilirubin. So without requirement for subjective assessment, like ascites and encephalopathy. And in comparison to MELD score, which by definition relates to end-stage liver disease, ALB is sufficiently sensitive to detect the early deterioration of liver function. So if a patient comes with features of early cirrhosis, ALB score will be a much more useful system than it will help to grade, categorize the basis of ALB from 1 to 3, 1 being best and 3 being the worst. So this is a early assessment tool rather than late assessment tool. Now the questions can be on portal hypertension. What is the normal portal pressure gradient and what is its value?
529, sir, mm of mercury.
Okay. Portal pressure is the difference between the portal venous pressure and the hepatic vein pressure or the inferior vena cava pressure. So oxygenated blood flowing from the portal. And the earlier picture I showed you, the portal venous pressure is only about 9 to 10 millimeter, and the hepatic venous pressure is 5 to 10. So this gradient has to be maintained for blood to flow from the portal vein to the hepatic vein. Even though both are called vein, portal vein has got higher oxygen values, whereas hepatic vein is a totally deoxygenated blood like any other normal vein. So this pressure gradient is important, and the normal range is 1 to 5 millimeters of mercury. How does the pH manifest at various values? The portal the hypertension. How will it? This is not the pH of blood. This is portal hypertension manifested various values of portal pressure gradient. What is the relationship between the portal hypertension and the portal pressure gradient? That is the question. other way of asking this question. Here, then the value of portal pressure gradient is 5 to 9. It represents subclinical portal hypertension. And when the pressure increases to more than 10 millimeter, portal hypertension complications are more likely to occur, such as formation of varices related to upper digestive bleeding, ascites, infection, etc. So normally it should be less than 10. And describe how ascites occurs in cirrhosis. This is another common question all of you may be knowing. So in cirrhosis, obstruction to portal flow, which leads to portal hypertension, and there is a shear stress, increase in vasodilator, and increase in flanking vasodilatation, trying to increase the blood flow. When the portosystemic shunting with vasodilatation occurs, and all this activation happens, the kidney is also playing an important role, so sensitive to renal circulation and all those things. And all these things you can find it in your book. And there is what is called the overflow theory of ascites. And the overflow theory is underfill, overflow, vasodilatation. These are the three things. So in cirrhosis, there is a primary renal sodium retention and also portal hypertension, peripheral arterial vasodilatation. All these things lead to portal hypertension causes ascites because of the constriction, decreased effective intravascular volume, renal sodium retention, increased blood volume, renal sodium retention. So primarily it is all because of the sodium retention leading to ascites. Once fluid starts accumulating, it goes on increasing, which is called the overflow fluid. And portal hypertension is classified. What are the causes? It can be pre-hepatic, intrahepatic, or post-hepatic. So classification of portal hypertension into three categories. One is pre-hepatic, intrahepatic at the liver level, or post-hepatic. And the causes of pre-hepatic are splenic vein thrombosis, portal vein thrombosis, congenital stenosis of portal vein, etc., and the AV fistula formation. Intrahepatic, it can be pre-sinusoidal at the sinusoidal level, which happens in cirrhosis, alcoholic hepatitis, amyloidosis, or it can be post-sinusoidal, veno-occlusive diseases. And post-hepatic, it can be hepatic vein thrombosis, as it happens in Budd-Chiari syndrome, constrictive pericarditis, and right heart failure. In these things, when you see the hepatic vein pressure measurement, there is a difference in all these three. So wedge hepatic venous pressure will be normal in all the pre-hepatic conditions. Similarly, the pre-hepatic venous pressure and hepatic venous pressure are all normal. In the intrahepatic, again, if it is pre-sinusoidal, it is all normal. At the sinusoidal level, you find the wedge hepatic pressure is increased, and the hepatic venous pressure gradient is also increased. But the pre-hepatic venous pressure is normal. And the post-hepatic conditions unable to catheterize a hepatic vein, then if it is constrictive pericarditis, you will find all these first two will be increased and the hepatic venous pressure gradient will be normal. So this is how we differentiate what is the location where the portal hypertension is happening. The prognosis, after assessing this, if you have the prognostic value of hepatic venous pressure gradient, if it is less than 5, it is normal. 5 to 10, mild portal hypertension. When it is more than 6, there will be progressive viral hepatitis will happen. And more than 10, clinically significant portal hypertension. And when it becomes more than 22, high mortality in severe alcoholic hepatitis. And gastroesophageal varices. What are the sites of portal travel anastomosis? This is a very common question they will ask you. What are the locations where there will be a communication between the portal vessels and systemic vessels?
Around the umbilicus, caput medusae, sir, it is called caput medusae, and lower end of the esophagus.
I guess.
Upper esophagus.
Lower esophagus, upper esophagus.
Lower esophagus only, sir. Sorry, sir. Lower esophagus.
What about the rectum for the signs? The signs are lower in the esophagus, where the esophageal varices is very, very common. Lower part of rectum, which may occur as hemorrhoids, and paraumbilical region, where it be caput medusae, it can be retroperitoneal, sometimes with colic veins and patent ductus artery venosus, intrahepatic porta systemic sac. So these are the 5 locations where it can happen. Lower end of esophagus, lower part of rectum, paraumbilical, which are the 3 common sites which we will clinically see. Or rarely it may be retroperitoneal, or it may be patent ductus venosus, which is intrahepatic portosystemic sac. How to treat esophageal varices? Does it require treatment or not?
Yes, sir.
What is the risk if you don't treat it?
Hypovolemia, it will cause
They
hypovolemia.
can bleed. They can bleed and produce massive hemorrhage. Okay, that is the most dangerous risk of that varices. Okay, so hematemesis, melena, and patient with portal hypertension, leading to if you put a vasoactive drug like terlipressin, endoscopy, do the confirmation, variceal ligation. So you can do a variceal sclerotherapy. If there is no bleeding, start beta blockers and complete the course of variceal ligation. Further torrential bleeding, balloon tamponade initially. How do you do the balloon tamponade? What tube you use?
Sangsten.
Sengstaken more tube. Sengstaken, not Sangsten. It is called Sengstaken more tube, which is inserted into the together, and there will be a balloon which will be distended. It is simply a pressure effect which reduce, because these are venous vessels. It will not have a thick wall, so you can occlude them. But the risk is once you deflate the balloon, there can be again a rebleed. Okay, so temporarily in an acute bleeding, you can stop that by introducing, but it is now become obsolete. Nobody uses that. And further non-terrestrial bleeding, further varices. So variceal ligation or sclerotherapy is the ultimate thing that we have to answer for that. And also there is a TIPS treatment. What is the TIPS stand for?
Transjugular intraperitoneal shunt, sir. Like
Intraperitoneal, intraportal systemic shunt. It is not peritoneal, intraportal systemic shunt. Okay? These are the things that you can do. And some things about hepatic encephalopathy, etiology of encephalopathy.
Is the ammonia, the end product of
the root cause is liver failure. Liver failure alone cause hepatic encephalopathy. Rare. It's mostly in acute liver failure. So most of the chronic liver failure is caused by variety of precipitating factors like excessive nitrogen load, that is protein-rich diet, GI bleeding, renal failure or constipation, electrolyte imbalance, drugs like sedatives or alcohol, or infections, UTI, bacterial pericarditis. These are all the etiology. How it is treated? Treated by diet control, reduced protein intake, non-absorbable disaccharide like lactulose, every day 45 ml hourly, orally, and 15 to 45 ml until intestinal movement is achieved. And lactulose O-lactitol, this is also can be given as an enema. And sodium benzoate, which eliminates ammonia hydride, 5 grams oral. And probiotics oral, ornithine aspartate to remove the ammonia again. N-acetylcysteine 100 milligram per kg IV or oral. So these are all the drug treatment. Then you have to give antibiotics, neomycin and metronidazole, rifampicin, flumazenil. To if there is a altered sensorium, you can use flumazenil and bromocriptine, dopamine receptor agonist. So these are all the treatment that we have to know how to treat hepatic encephalopathy. And hepatorenal syndrome, also known as functional renal failure. How is it treated? So portal hypertension leading to flanking vasodilatation, decreased effective circulatory volume, leading to renal vasoconstriction, leading to hepatorenal syndrome. So the treatment principles are regarding the pathophysiology. You can try to control portal hypertension. For that, you can try tips in the early stages. Then we try to do liver transplantation as early as possible. The presence of hepatorenal syndrome is an important indication for early liver transplantation. And that is how the ultimate treatment success of this condition is done. And if there is not enough chance of doing an early transplantation, then you can go for renal replacement therapy. And we can try for vasoconstrictions and albumin. And if there are toxins, you can remove them by this MARS, metabolic. This is something like a dialysis for the liver is MARS. That can also be done. Now, hepatopulmonary syndrome, portopulmonary hypertension. These are the liver, respiratory complications in liver disease. This is also asked in the examination. What are the mechanisms? These are all available in the book which you can read, of course. So the hepatitis injury, portal hypertension leading to main thing is nitric oxide effect is completely blocked. So that is all that happens. And inflammation and vasoactive changes and genetic factors lead to endothelial cell damage, smooth muscle, vasoconstriction remodeling. So the lung gets affected. If you see this picture, these two things, how they happen, portopulmonary hypertension, you find this is the normal alveolus, and this is the capillary that is supplying there. It has got a diameter of 8 to 15 microns. Here it becomes less than 8 to 15 microns. So the pressure is, vasoconstriction is occurring. The diameter is reducing. And so there is a vascular obstruction due to proliferation of smooth muscle cells. You can see the number of smooth muscle cells are increased, and the endothelium and platelet gets aggregated in this condition. Whereas the alveoli is almost normal in all these things. And in hepatopulmonary syndrome, the capillaries get dilated and angiogenesis happens. It increases in diameter from 15 to 100. So portopulmonary hypertension, mainly capillary vasoconstriction. In hepatopulmonary syndrome, mainly pulmonary capillary dilatation. These are the basic physiology that happen, due to which alterations in the alveolar gradient, everything will happen. Why patients with DCLD have hyperdynamic circulation?
Due to
We
bounding
saw in the
parts.
earlier thing that it will produce bradycardia, vasodilatation, almost suppression of cardiovascular function. They are more prone for hypertension. I showed it in the earlier slide like that. But normally, when you palpate the pulse, it is a hyperdynamic
Bounding pulse.
circulation, lasting pulse. Okay. So accumulation of prostaglandins and interleukins, which are vasodilators, cause increase in the output and decrease in SCR, resulting in hyperdynamic circulation. So it has nothing to do with the bile salts, which normally act on the SO node to cause the bradycardia. So it is the prostaglandins and interleukins, which are vasodilators, which cause an increase in cardiac output and decrease in SCR, resulting in hyperdynamic circulation. And there is a reduced blood viscosity due to high hypoalbumin and anemia, which also plays a role. So increased production of vasodilators, resistance to vasoconstrictors is there, so resulting in vasodilatation in splanchnic area, reduced systemic vascular resistance in artery blood pressure, hyperdynamic circulation because of to compensate for this. What other serious pathologies can happen? It can produce cardiomyopathy and diastolic dysfunction. What changes in coagulation occur? Of course, we have seen that earlier also. So platelet dysfunction, thrombocytopenia, hemostatic balance is reduced, fibrinolysis, dysfibrinolysis. So all steps of coagulation cascade can be altered. And so this is another picture to show how primary hemostasis is affected, how coagulation is affected, and how fibrinolysis is affected. And how to optimize patients with BCLD and cirrhosis. Before any surgery, how do you optimize them?
Correct the electrolytes and
Nutrition as state, very lean body mass, serum albumin, biceps skin fold, mid-arm circumference, and measurement. Okay? So that is a very, very important step. Hypoglycemia due to diminished hepatic gluconeogenesis, which should be corrected. Hyponatremia is common due to excess free water. Treat with aldosterone antagonist and low salt diet. Correct potassium level. Watch for early signs of encephalopathy. Oxygen saturation in room air for septopulmonary syndrome and portopulmonary hypertension syndrome. And paracentesis to improve oxygenation and prevent aspiration with more than 4 liters to stap infuse albumin. And earlier days they used to do what is called leave-in shunting, used to absorb the fluid and direct it into the circulation itself. So continuing with the optimization, correction of coagulopathy, check platelet fibrinogen, inject vitamin K for 3 days, fresh frozen plasma, cryo or platelet as per TEG values, prevent infection and sepsis. Tips can be done in selected cases for proprietary ascites or decreased renal function. And MARS, molecular absorbent recirculating system in cases of toxin and drug. So these are all the optimizations that you can think of. What are the goals of anesthetic management for patients with BCLD? Preserve hepatic blood flow. That is the primary goal. Factors which decreasing hepatic flow according to our anesthetic technique, mechanical ventilation and feed, hypercarbia, hypoxia, hypotension, stress of surgery. So monitor and maintain renal function. This is the second goal. And prevent CNS depression and encephalopathy. This is the third goal. And fourth goal, prevent coagulation failure. And fifth is maintain normoglycemia. Sixth is preserve electrolyte balance. Anesthetic management of the patient, they have altered pharmacokinetics. There will be an increase in volume of distribution, decreased protein binding, and decreased clearance of drugs. All these three things happen in these patients with chronic liver disease. So, induction agent of choice, propofol, because it has extra hepatic elimination route and also it preserves the hepatic arterial buffer response. Relaxant of choice is cisatracurium because it is not dependent on any hepatic or renal route of elimination. Analgesics, remifentanil, titrated doses of fentanyl. Inhalation agent, ISO or CO, which preserve the hepatic arterial buffer response. Reversal with titrated doses of neostigmine. Monitors, routine in mild to moderate cases, invasive monitoring in severe cases. Regional anesthesia, it says if their coagulation is okay and SVR is not too low and the level of block required is below T10. In these cases, you can go for central neuroscial blockade, but three conditions you have to fulfill are coagulation should be normal, patient's diastolic blood pressure should not be too low, and the level of block required should be below T10. Post-op care, watch for features of acute liver failure in the form of altered sensorium, increasing jaundice, and monitor renal function, monitor coagulation, avoid infection. Paracetamol 2 to 3 grams is safe for patients with liver disease also. LA techniques for pain relief, wherever possible you can do any local anesthetic complementary technique. So the other things that we have to know about, these are all the points that you have to remember with regard to the liver. Types of cases: cirrhosis with portal hypertension, obstructive jaundice, CBD stone, cancer head of pancreas, segmental hepatectomy for secondary deposits, end-stage liver disease for liver transplantation. So these are all the types of cases that can be kept in the examination. And anesthesia for ERCP, that is what I just gave you. And what she said is also important. Here, in addition to the chronic liver problem, you have the patient going in for a procedure in the non-operating room anesthesia. It's a NORA procedure. And as she rightly said, it may be done in the lateral or in the prone position also. And depending upon that, we have to think of securing the airway. If it is lateral position, we can think of conscious sedation also. Some people do that. Otherwise, you can think of the procedure what she described. But the airways can be secured with a gastro-LMA or by direct endotracheal intubation. And if the ascites is severe, it is always safer to go for endotracheal intubation and secreting and isolating the airway so that the chances of vomiting and aspiration are prevented. So these are all the things that you have to remember with regard to liver and anesthesia.